Hygiene's update on COVID-19 for New York City healthcare providers. As always, please note that you have been placed in listen-only mode. So if you have questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. The slides from the webinar, as well as a recording of the event, will be made available on our provider webpage on our website by tomorrow afternoon. And we also thank you for your participation in a brief poll that will be issued during the last 5 minutes of today's webinar. Today, we're joined by staff from the agency's COVID-19 Vaccine Operations Center to discuss COVID-19 vaccine clinical considerations, safety monitoring, and frequently asked questions, as well as recent epidemiology of COVID-19 in New York City. And with that, I will hand it over to Dr. Mary Flitt, Health Systems Planning and Strategies Lead for the agency's outbreak response.
All right. Thank you so much, Ellie, as always. And good afternoon, everybody. Thank you for joining us. Next slide. All right. So we'll just be covering a couple new developments and guidance, and then we'll turn it over to my colleague, Dr. Annie Fine, for the Epi updates for New York City. And then we have a really wonderful presentation lined up for you on vaccine safety and monitoring. And then we're going to have some wonderful guests here for a more deep dive panel discussion with Q&A. Next slide. All right, so where are we right now? So worldwide, we have about 103 million cases reported with over 2.2 million deaths. In the US, we are seeing now a decline in case numbers, hospitalizations, and daily mortality rates, which is, of course, an encouraging and good sign. We are starting to see some similar trends in New York out, we hope, which will be a World Health Organization team finally was able to begin investigations on the origins of COVID in Wuhan, China, and they have been visiting and continue to visit labs, markets, and hospitals in Wuhan. So we look forward to hearing the results of that. In some great vaccine updates, there were interim results of the Johnson & Johnson phase 2 trial, which showed an overall 66% efficacy in preventing moderate to severe COVID, and more importantly, 85% efficacy in preventing severe COVID-19, and 100% efficacy in preventing death, which of course is, I think at the end of the day, the most important for a vaccine. Johnson & Johnson, just as of yesterday, has applied for an FDA emergency use authorization, so we expect to hear a decision about that soon. And just as a reminder, this Johnson & Johnson is the one-dose vaccine, so it is applying for EUA for one dose, but it is also doing studies for a 2-dose regimen as well. So we'll hear more about that later. Also, interim results of the Spike vaccine, which is a Russian-developed vaccine. They published results in Lancet this trial, which showed 92% efficacy in preventing symptomatic COVID-19, and again, 100% efficacy in preventing severe COVID-19 and death. And just as a reminder, this is an adenovirus vaccine technology, and interestingly uses a different adenovirus for between the first and second dose. So that's sort of an interesting innovation. And then the U.S. will join the World Health Organization COVAX program to contribute toward providing access to COVID-19 vaccines in low and middle income nations. So hopefully we will see a lot more to come on that. Next slide. And I think this is a really important topic that we get a lot of questions on. How do the emerging variants that we've been discussing over previous calls, how does that seem to be impacting vaccine efficacy? So Pfizer and Moderna have conducted in vitro studies of vaccine efficacy against recently identified variants, particularly the UK variant and the South Africa variant. Impact on plaque reduction neutralization assay. So basically, the lab, looking at this in the lab, how well the antibodies seem to work against COVID. And with the UK variant, there were no significant impacts on neutralization, but looking at the South Africa variant, there was still neutralization, but it was reduced. And so Moderna has announced already plans to test whether a third shot, basically to make a tweak to their mRNA to be better matched with the mutations in this new variant, and to look at whether a third shot or booster shot will enhance this immunity to this new strain. And in Johnson & Johnson, they did actually in their data report that they reported efficacy for both the US and for South Africa. So the efficacy was 57% in South Africa, and that was when the variant strain was already circulating, and it was 72% efficacious in the US against our circulating strains previous to the variant introduction. And I think, again, 95% of the South African COVID cases that were identified during the trial were due to this variant. Apologies. And then lastly, the Novavax protein subunit vaccine efficacy was overall 95.6% efficacious against the original COVID-19 strain, and it was found to be 85.6% against B117, which is the UK, and 60% against B1351, which again is the South African strain. Next slide. And monoclonal antibody updates. So this is something that we are going to go into a much deeper dive in the next webinar when we're going to have some, hopefully introducing some new resources, but I wanted to give some important updates on data that was released, unfortunately not in peer-reviewed journals, but through press releases. We got some preliminary data from trials that are being done on both Regeneron and by Eli Lilly for bamlanivimab. So just as a reminder, monoclonal antibodies, the monoclonal antibody therapies, they are targeted against SARS-CoV spike protein for treatment, and now studies looking at prevention of COVID-19. And there is already an EUA granted for the treatment of outpatients at risk for, particularly at risk for severe illness and hospitalization with initial infection with mild to moderate COVID-19. So this is not approved to be used in hospitalized patients, and we'll go into that a little bit later. But bamlanivimab and Regeneron have shown both shown reduced rates of ED visits and hospitalization in outpatients with confirmed mild to moderate disease, and also both have demonstrated a statistically significant decrease in viral loads in study patients receiving the treatment. And so newly released data on a combination treatment with bamlanivimab and etesevimab combination treatment, which is a new product, which would be a new product combination. This results said treatment reduced the risk of hospitalizations or deaths 70% in a cohort of over 1,000 patients with newly diagnosed COVID-19. In the outpatient setting, there were 10 deaths in the placebo recipients. No deaths occurred in the treatment group. So this is from the Blaze 3 trial, which will be hopefully be releasing data in a peer-reviewed journal soon. And then there were two really interesting studies on prevention of symptomatic infection in contact. So the EUA is for treatment of already infected patients. So this is something that they're looking at for prevention. And the study with bamlanivimab that was announced showed that there was a reduced risk of symptomatic COVID by 80% in a study of nursing home residents and employees that were experiencing an outbreak. So in that cohort, there were 299 residents in the prevention group that received either bamlanivimab or a placebo, and there were as mentioned, there was a reduced risk of symptomatic COVID by 80%, and there were 4 deaths in this group. All were in the placebo group. So this shows, particularly in this very high-risk population, that's very encouraging and promising data. So we look forward to hearing more when that is published. And then also looking at Regeneron, they presented preliminary results on a study looking at contacts, so household contacts of confirmed COVID cases received treatment with either Regeneron or a placebo, and then they followed them to see who developed symptomatic and asymptomatic infections. And they did find that there was a 50% reduction in and completely prevented symptomatic COVID infections. So that, again, was also very encouraging. And I think really interestingly about this trial is that this was looking at using it or delivering it as an injection instead of an infusion, which would make it much easier to deliver. Next slide. And just, you may have hopefully seen a health alert that was just sent out this week about the importance of reporting race and ethnicity data in vaccine reporting. We really just want to highlight, I think we all know COVID-19 has really laid bare enormous racial and ethnic inequalities that are driven by historic and ongoing structural racism. And we have a new tab on our vaccine data page, which does show a breakdown in our race and ethnicity data for who's receiving the vaccine. We have about only 40% reported. So, in order to really be able to know, how equitably the vaccine, we have unknown race ethnicity data for 40% of vaccine recipients. So really in order to have a better understanding of how equitably the vaccine is being distributed and received, so we can, really target interventions and resources to the groups that are not getting it, that need it, we really need the race and ethnicity data to be completed. So this is just our humble ask of you all to please support these efforts by ensuring that these data are as complete as possible for patients that are being vaccinated. Next slide. And I did just want to, acknowledge that this is the beginning of February, the beginning of Black History Month. I know there are some amazing historical figures that we could highlight, but I did want to take an opportunity today to highlight a couple of the really amazing women that have made history over the last year. Next slide. So Dr. Kizzmekia Corbett, she is a viral immunologist and research fellow at the National Institute of Allergy and Infectious Disease. And she has really been leading the team that has, for the vaccine research for COVID-19 in particular. She's been the lead scientist on the Moderna COVID-19 vaccine. And she has been, doing work on this technology with other viruses for several years. So she really had the groundwork laid that within 2 days of having the genomic sequence of COVID released, she was able to incorporate that into the mRNA sequence and get that over to Moderna, who within 66 days of that was able to start the phase 1 trial of the Moderna vaccine. And so this is really putting amazing research and work into real operational action to make a huge impact on the life of not just New Yorkers, Americans, but all over the world. So that's an amazing accomplishment that deserves a lot of recognition. And just of note, she is an amazing scientific, really very skilled and amazing communicator, especially scientific communication, making it accessible. And she's been just a great advocate for the need for improving diversity and representation in the sciences. So she's had some great podcasts out recently. So I just encourage you to take a look and take a listen if you get a chance. She's really an extraordinary woman. Next slide. And then, of course, we would be very remiss if we didn't highlight one of our own, Sandra Lindsay, who is the Director of Critical Care Nursing at Long Island Jewish Hospital. Many of you probably recognize her as the first person in the U.S. to get a COVID vaccine outside of clinical trials on December 14th. And she is not only a hero for that, and she very explicitly said, she wanted the vaccine not only to protect herself, but also to, really show people that looked like her that the vaccine is safe. And she's been, a really big advocate for and spokesperson for helping to the need to improve trust and earn the trust of communities of color in our vaccine efforts. And not only that, she led teams of over 100 nurses, and not just ICU nurses, but all the affiliated teams during the COVID response at her institution, which again, she's a hero in many ways. So we're happy to be able to recognize her. So next slide. With that, I would like to turn it over to my colleague, Dr. Annie Fine, to go through some of our epidemiology updates. Thank you.
Thank you so much, Mary, and thank you for those fascinating little mini biographies, really inspiring. So I have the privilege of speaking to you today about what's going on in New York City recently in terms of epidemiology. I will say that all of what I'm going to show you, I believe, is available on our website, so I would encourage everybody to use that website frequently. We put a ton of data up there. And I will also note, I don't think I have this in the slides, but we just put up a new feature, which is, if you go to our website by Googling COVID New York City data, you will see there's a tab that's called Data by Zip, and anybody can put in their own zip code, and you can see sort of a wealth of data about that individual zip code, and as well as how it compares to other zip codes all across New York City. So I'd encourage you to check that out. Okay, next slide, please. So this is just a summary of the key data points as of, I believe it was yesterday. So luckily you see, this is actually the first time in a long time I've seen green on the whole, every indicator. So we have our percent positive over the last 7 days is declining. It's at 8.5%. Our confirmed cases are declining. Our probable cases are declining. And total number of cases in the last 7 days was about 30,000, which is still an enormous number, and obviously one which we want to see continue to decline. Hospitalizations also appear to be decreasing. I will say with our hospitalization data, sometimes there's a lag and sometimes it's incomplete. So I hope this is the case, but this is as of the data that we have, they do appear to be decreasing. And then this is the first time in a while I've also seen confirmed deaths decreasing. So, but we still have a very high number of deaths occurring each week. Next slide, please. Okay, so this is just an Effic curve which shows confirmed cases in the blue and probable cases in the gray. And you can see that our case counts have stabilized. Our peak case count was around in the end of the first week of January, and case counts have been declining since then. So we are watching this very carefully. Our real concern, as I'm sure most of you know, is the emergence of these new variants, which are more transmissible. So far in New York City, we've only seen the B117 variant, and we've only seen small numbers, but the small numbers are likely related to the very low amount of testing. So far, we're ramping up our genetic sequencing capability across the city, and we'll be following that very, very closely. So we really don't know how much B117 there is in the city, but we do know there's probably a low proportion of all the viruses that are circulating currently. The last 7-day average of cases is about 5,500 per day. So we're still at a very high level. Next slide, please. This is just a curve showing the hospitalizations, and these are the 7-day average is about 350 per day. And then again, we're watching this similarly to the cases. Next slide. Citywide deaths. have continued to go up and only recently started to flatten out a bit. We are now close to about 80 COVID-19 deaths per day in the city. Next slide. So this is a curve showing the number of people tested, both by PCR and antigen. And though it fluctuates greatly, you can see the sort of darker blue line, which indicates the 7-day average. And the 7-day average recently for PCR is about 65,000 people per day, and for antigen, it's about 18,000 people per day. We're seeing a slight trend of increasing people being tested by antigens and a stable trend for those being tested by nucleic acid amplification testing. The average turnaround time is still pretty good, 2 days. So it's holding steady. I think the labs have been doing a really amazing job of turning around these very, very large volumes of tests. Next slide, please. This is just a map which shows the percent positivity across the city, and the darker color reflects the highest percent positivity, which is up to 16, as you can see in the figure at the top, the legend. Flushing, Murray Hill, and Queens has our highest by zip code, although there are microclusters in these areas that are quite a bit higher. And then followed by Brighton Beach in Brooklyn, South Brooklyn, and then Midwood in Queens and Woodhaven in Queens. Those are our kind of hot spots in the city right now. But as I said before, we are seeing this sort of stabilization or slight decrease in percent positivity citywide. Next slide. Okay, and this is my last slide, and this just shows the number of doses of vaccine that have been administered in the city to date. We are approaching 900,000 doses, of which 630,000 were the first dose, and these are the doses administered in the city. They're not all necessarily New York City residents. And then second dose, 155,000 people have received the second dose in New York City. So we are seeing increases in those numbers. I'm going to turn it over now to my colleagues in the vaccine programs who are going to, I don't know if they're going to present further data, but can discuss this next slide, yes, which are the demographics of the people who have been vaccinated. And I'll stay on for a bit to answer any questions if anybody has any too. Thank you so much.
Thanks, Annie. This is Bindi Crouch from the Bureau of Immunization. And so I'm just going to say a few words about this next slide here. And again, this information is available also on our website, which now shows vaccination information. This slide shows adults, and this is where I want to be very clear here, that this shows race and ethnicity for those adults that had race and ethnicity reported. And I know Dr. Foote pointed out at the start of her presentation that 40% of vaccine doses administered do not have our race and ethnicity reported. So we are really doing a push around the city with our healthcare providers to ensure that this information is reported. But based on those, based on the data that we do have in the 18 to 64-year-old category, we see that there is about a 41% of persons vaccinated are describe themselves as white, 19% Asian, 16% Latino, and 11% Black. Among those who are 65 years and older who have been vaccinated, I should have pointed out that this is with at least one dose of vaccine. So among those 65 years and older, again, among those individuals for whom race and ethnicity were reported, we have 54% reporting as white, 12% of individuals who report themselves as being Asian, 14% who report themselves as Latino, and 11% reporting themselves as Black. I do want to note that that also was our New York City data. We have those individuals vaccinated in New York City who are not from or are not residents of New York City on the below portion of that graph, and I'll give you all will have the opportunity to review that data yourselves on our website. But in the meantime, I just want to really, what Mary said earlier on about reporting race and ethnicity data, I just want to really encourage all of you to ensure that all of your staff, especially those who conduct the patient intake, as well as those administering vaccines, to make sure that they understand the importance of this data and why they are being requested, and additionally how they will be used. So instruct your staff to explain to patients how they will be used. For instance, you may say, as part of our efforts to make sure we are doing our best to meet the health needs of our patients, we ask all patients about their race, ethnicity, and ancestry. You should ask recipients to report their own race and ethnicity. Never assume someone's race or ethnicity based on appearance, languages spoken, or other observations, of course. Recognize that ancestry and heritage fields may not be standard in electronic health records, and that you may need to adjust your questions accordingly. And then it's important to reassure vaccine recipients that immigration status is not being requested. So we really appreciate all of your efforts thus far with the COVID-19 vaccination campaign. And with that, I'm going to turn it over to my colleague to talk about vaccine adverse events and safety.
Good afternoon. Next slide, please. In this presentation, I will discuss clinical considerations for the 2 mRNA COVID vaccines currently authorized for use, who should not get vaccinated and who can get vaccinated. I will describe the systems in place for vaccine safety monitoring, and I will end by sharing some reassuring news with information on initial results of this safety monitoring, including an update on anaphylaxis. Next slide. We have 2 highly effective COVID-19 vaccines authorized and recommended for emergency use. In clinical trials, the Pfizer vaccine was shown to be 95% effective, and the Moderna vaccine 94% effective at protecting against COVID-19. Both vaccines were shown to have high efficacy across age groups, genders, racial and ethnic groups, and people with medical comorbidities. Both vaccines were shown to be safe with no significant safety concerns in clinical trials, and this held true across demographic groups, patients with and without comorbidities, and with or without prior infection. Next slide. Information from these large clinical trials additionally have informed us that the COVID-19 vaccines are likely to cause mild to moderate adverse reactions after vaccination. And this is especially true after the second dose. Commonly reported reactions included pain and erythema at the injection site, fatigue, headache, myalgia, chills, and fever. They were more common among younger compared to older age groups, and more often they occurred within the first 3 days of vaccination and resolved within 1 to 3 days of onset. You can reassure your patients that these reactions, characterized as reactogenicity, are common and they are signs that the immune response is working. Next slide. It is important to prepare your patients for these common and expected reactions. Unless a person develops a contraindication to vaccination, which we will discuss in the next couple of slides, they should be encouraged to complete the series to optimize protection against COVID-19. Antipyretic or analgesic medications may be taken for treatment of post-vaccination symptoms. Routine prophylaxis to prevent symptoms is not recommended, and this is due to the lack of information on impact of their use on vaccine-induced antibody responses. Next slide, please. Who should not get vaccinated with an mRNA COVID-19 vaccine? The answer is anyone with a previous severe or immediate allergic reaction to a COVID-19 mRNA vaccine dose, a vaccine component, or polysorbate. Next slide, please. The contraindications and precautions to COVID-19 vaccination will be updated as the experience with the vaccine increase. A history of the following is currently considered a contraindication. Severe allergic reaction, for example, anaphylaxis, after a previous dose of an mRNA COVID-19 vaccine or any of its components. An immediate allergic reaction of any severity to a previous dose of a mRNA COVID vaccine or any of its components, including polyethylene glycol or PEG. Immediate allergic reaction of any severity to polysorbate due to the potential cross-reactive hypersensitivity with the vaccine ingredient PEG. Immediate allergic reactions are defined as hypersensitivity-related signs or symptoms consistent with urticaria, angioedema, respiratory distress, for example, wheezing or stridor, or anaphylaxis that occur within 4 hours after vaccination. Next slide, please. Who may get vaccinated with a COVID vaccine? And really the answer to this question is most other persons older than 16 years right now. But I will be specifically speaking about the following groups of people who may get vaccinated after considering the risks and benefits. They include persons with a history of severe or immediate allergic reaction to any vaccine or injectable. And these are persons who should be observed for 30 minutes, pregnant and breastfeeding persons, persons with certain immunocompromising conditions, and persons with autoimmune disease. Next slide, please. A history of any immediate allergic reaction to any other vaccine or injectable therapy is considered a precaution, not a contraindication. Counsel persons with such a history regarding the unknown risk for severe reaction and balance this against the benefits of vaccination. Consider consultation with an allergist or immunologist. Allergic reactions not related to vaccines, injectable therapies, components of the mRNA COVID-19 vaccines, or polysorbates are not a contraindication or a precaution. Next slide, please. Persons with a history of an immediate allergic reaction of any severity to a vaccine or injectable therapy and persons with a history of anaphylaxis due to any cause should be observed for a minimum of 30 minutes. And the recommendation is for all other persons to be observed for 15 minutes. Next slide. Pregnant or lactating persons may choose to be vaccinated. Pregnant people are at risk for severe illness due to COVID-19. There is limited data on the safety and effectiveness of vaccines in pregnant and lactating people. However, based on our current knowledge, vaccines are unlikely to pose a risk to the pregnant person, fetus, or breastfed infant. Consider the level of community transmission and the risk of COVID-19 to the patient and potential risk to the fetus. If pregnant persons develop fever after vaccination, they should take acetaminophen, as fever during pregnancy can negatively affect a fetus. Acetaminophen is safe in pregnancy. The American College of Obstetricians and Gynecologists, or ACOG, recommends COVID-19 vaccines. They emphasize that vaccines should not be withheld from pregnant people and should be offered to lactating people. Next slide. Clinical trials demonstrated similar safety and efficacy in persons with some underlying medical conditions, including those that place people at increased risk for severe COVID-19 compared to persons without comorbidities. Individuals in all the following groups may receive COVID-19 vaccination unless they have a contraindication to vaccination, and I will be talking about these groups separately. Next slide. Persons with HIV infection or other immunocompromising conditions or who take immunosuppressive medications may be at increased risk for severe COVID-19. They may receive COVID-19 vaccination if they have no contraindications to vaccination. Persons with stable HIV infection were included in the vaccine clinical trials, though data are limited. Counsel patients about the unknown vaccine safety profile and effectiveness in immunocompromised populations, as well as the potential for reduced immune responses. Antibody testing is not recommended to assess for immunity following vaccination. Next slide. Persons with autoimmune conditions may receive COVID-19 vaccine if they have no vaccine contraindications. They were eligible for enrollment in the clinical trials. Inform patients that limited data are currently available on the safety of mRNA COVID-19 vaccines for people with autoimmune conditions. No imbalances were observed in the occurrence of symptoms consistent with autoimmune conditions or inflammatory disorders in clinical trial participants who received vaccine compared to those who received placebo. Next slide, please. And who should get vaccinated but wait for the appropriate time? These include persons currently isolating or experiencing COVID-19 symptoms. They should wait until symptoms have resolved and they are finished with isolation. Persons who recently had COVID-19 and were treated with antibody-based therapies should wait until 90 days after treatment to be vaccinated. Persons who recently got another non-COVID-19 vaccine should wait until at least 14 days before getting COVID-19 vaccine. Next slide, please. People with prior infection or exposure to COVID-19 should be offered vaccination to reduce the likelihood of reinfection. Since reinfection is uncommon in the 90 days after initial infection, people with documented acute SARS-CoV-2 infection in the preceding 90 days may choose to temporarily delay vaccination until near the end of this period, if so desired. Testing people without symptoms for evidence of current or past SARS-CoV-2 infection for the purpose of vaccine decision-making is not recommended. Defer vaccination for people with acute infection or in quarantine to avoid potentially exposing healthcare personnel or patients to SARS-CoV-2 during the vaccination visit. People with acute infection should wait until their isolation period has ended. Persons exposed to someone with COVID-19 should defer vaccination until after their quarantine. Next slide, please. And now to describe the vaccine safety monitoring systems in place for COVID-19 vaccines. The Pfizer and Moderna COVID-19 vaccines were developed more quickly than previous vaccines, and this was due to the urgent need and with special funding. They underwent the same level of robust study as previously approved vaccines. Safety was monitored closely during every phase of vaccine development. Tens of thousands of participants in clinical trials safely received vaccines. Safety and efficacy data from clinical trials were reviewed carefully before authorization by FDA and before recommendation by ACIP, or the Advisory Committee on Immunization Practices. Vaccine safety monitoring continues after their approval. The COVID-19 vaccine safety is currently being monitored closely through multiple large, robust systems. Next slide, please. And here is a list of some of the systems involved. There are numerous systems using different methods of surveillance, both active and passive, covering many, many millions of people across different populations. I will focus on VAERS and VSafe because in these two systems we have an important role. Next slide, please. VAERS is the Vaccine Adverse Event Reporting System. It is the nation's frontline system for monitoring vaccine safety, and it is co-managed by FDA and CDC. It is designed to rapidly detect unusual or unexpected patterns of events, also known as safety signals. VAERS covers the entire U.S. population, accepting reports from all. All serious reports are reviewed by CDC and FDA scientists, and these include death, life-threatening illness, hospitalization, disability, birth defects, and other conditions that may be specified in the EUA. CDC and FDA coordinate on the analysis of VAERS data, applying statistical methods to detect disproportional reporting of specific vaccine adverse events. If a safety signal is found in VAERS, further studies can be done in other safety systems, which can better assess health risks and possible connections between adverse events and a vaccine. Next slide, please. Adverse events that occur following COVID-19 vaccination should be reported to VAERS. Vaccination providers are required by the FDA to report the following that occur after COVID-19 vaccination under the EUA: vaccine administration errors, serious adverse events, and this is irrespective of attribution to vaccination, cases of multi-system inflammatory syndrome, and cases of COVID-19 that result in hospitalization or death. Reporting is encouraged for any other clinically significant adverse event, even if it is uncertain whether the vaccine caused the event. Information on how to report through VAERS is available on their website, listed here, or by calling this number. Next slide, please. VSafe is a new smartphone-based active surveillance system established for COVID-19 vaccines. It uses text messaging to initiate web-based survey monitoring. Electronic health checks are made daily during the first week after vaccination, and then weekly thereafter for 6 weeks after vaccination. Additional health checks are made at 3, 6, and 12 months post-vaccination. There is active telephone follow-up with persons who report clinically important events, and those include those that cause one to miss work, to not be able to do their normal daily activities, or to seek health care. And this initiates a VAERS report. All COVID-19 vaccine recipients are eligible. Healthcare providers should encourage participation. Next slide, please. Next slide. Okay. Thank you. I want to give a background on anaphylaxis after COVID-19 vaccination. On December 9th, 2020, there were 2 reports of anaphylaxis reported in the UK. Subsequently, Pfizer and Moderna included information on anaphylaxis in their product information. The ACIP considered the risk of anaphylaxis during their deliberations. CDC recommended risk mitigation strategies, including screening for the risk of anaphylaxis before vaccination, monitoring for symptoms post-vaccination, and early recognition and management of anaphylaxis at vaccination sites. Additionally, enhanced monitoring for anaphylaxis in VAERS was initiated. Next slide, please. And for your reference, here is where to find CDC's guidance on preparing to manage anaphylaxis after COVID-19 vaccination. Next slide, please. VAERS has been intensely examining anaphylaxis reports. Last week, during an emergency ACIP meeting, VAERS reported updated rates of anaphylaxis, and this is as they have accumulated more information. For Pfizer's vaccine, they estimate a rate of 5 per million doses administered. And for the Moderna vaccine, there's an estimated rate of 2.8 per million doses. In their initial reports that were published in the MMWR, they described a rate of 11.1 cases of anaphylaxis per dose of Pfizer vaccine and 2.5 cases per million doses of Moderna vaccine. So as you can see, as the data matures, it is looking as though the rates of anaphylaxis are lower than what was initially reported. Next slide, please. During this time, the U.S. government has implemented the most intense and comprehensive vaccine safety monitoring program in history. And what has this information told us so far? Safety profiles of COVID-19 vaccines are reassuring and consistent with that observed from the pre-authorization clinical trials. Anaphylaxis has been observed following mRNA COVID-19 vaccines, though this remains rare. Data do not suggest a signal with respect to overall safety or death following vaccination. Additional population-based monitoring systems will continue to gather safety data as vaccination increases and the immunization program broadens. Next slide, please. I would like to end with what our role as vaccine providers is in COVID vaccine safety monitoring. First, provide an EUA fact sheet to each vaccine recipient. This is especially important and required as part of the provider agreement. Second, talk to your patients about possible reactions after vaccination and vaccine safety. Report adverse events to VAERS. And finally, encourage participation in vSafe. Next slide. Thank you for your time and thank you for all that you do. Oh, and here are some additional resources.
Okay, thank you so much. And I think we have a few, in addition to Dr. Iwamoto, I think we have a couple other colleagues on the line, including Dr. Crouch and Dr. Zucker from our vaccine task force or vaccine operations center that are wonderful resources. So I think we can go ahead and get started with some of the question and answer session. So we had one question on reporting, specifically about why the purpose of the questions about gender identity and about sexual preference. And what is that used for?
Hi, Mary. This is Bindi. Thank you for that. So at this time, we collect demographic information so that we can ensure we're reaching all populations within our communities and ensuring that we have equitable access of vaccine. So that is why we currently collect that demographic information.
Great. Thank you, Dr. Crouch. And we have several questions that have been around vaccine guidance and post-vaccine guidance. One that just came up. So if a person, do we have any recommendations about or thoughts on checking for antibody response after you've gotten the vaccine? Through going get blood work for antibody testing to see if you've responded?
Hi, this is Martha. No, there are no recommendations for serology following vaccination.
All right. And just to clarify, because I know I've gotten questions about this before, but it would show up, if you did have immunity from the vaccine, it would show up in the regular antibody tests that are available commercially. Is that correct?
That is my understanding. Yes, so getting a COVID vaccine does not affect, molecular tests or antigen tests, but it does affect your serological assays.
Okay, great. Okay, and I think just in the post-vaccine bucket, we also had, there were a couple questions about the concern about giving acetaminophen or NSAIDs after for pain and fevers, that it might blunt an immune response or antibody response. Can one of you comment on that?
Hi. Now, these are okay after vaccines in order to treat patient symptoms. That's okay after getting a vaccine. There is a recommendation against pre-treatment, though, however, because of these concerns.
Okay, great. Thank you so much. And I think there were also just generally, if someone wanted to talk about, just some of the reasons why after vaccination and somebody has, waited 2 weeks after their second dose, in terms of protective measures that you should still be taking, the reasoning behind that, and if there should be any concerns after if you've had, for example, an unknown exposure to COVID after having received the vaccine, and how would you manage that?
Yes. Thanks, Mary. I don't think that we have the guidelines out on this yet. However, I will say that it is recommended that you continue to follow all of the public health guidance for this particular pandemic. We do know that the vaccines are not 100% effective, so there is always the chance that you could still become infected. We also, most of our efficacy is looking at illness and disease as opposed to asymptomatic infection. So there is also not enough data at this time to determine whether or not asymptomatic or how well asymptomatic transmission may occur in a vaccinated individual.
There was a question that I think we can answer pretty easily, which is the fact that we don't know. But the question is, how long is the immunity to COVID last after getting the vaccine? And I think that will be an only time can tell sort of situation.
That's right, Mary. We just haven't had enough time following enough follow-up period for our trials as of yet to know how long immunity is going to last.
Great. And I think we did have several questions, and unfortunately this is, a well-reported phenomenon where patients get the first dose
Hi, Dr. Foote. I think that we are having some issues with the audio. So for those who are unable to hear, that might be what's going on. Dr. Ray, are you able to pick up on the last question?
Oh, sorry.
Oh, are you back, Dr. Foote?
Can you hear me?
You're back, great.
Yes, you're back. Okay, great.
Okay, so I'll finish this question, and then I think we had one from Dr. Ray. So essentially, it's someone that has been vaccinated, gotten their first dose, and then unfortunately had been exposed to COVID and then develops a positive infection. When I know there's sort of a formal recommendation about this, that you should at least wait until they pass our isolation period, but would you recommend they get then scheduled for their second dose on schedule, or do you recommend they wait the 90 days after for their second dose after infection?
I would not wait for the 90 days. That person should get their second dose as when they are done with their quarantine.
Great. And I think on a similar note, there was a sort of chatter this week. I'm not sure what the data was on it, but whether somebody is vaccinated that has a history of prior infection, is there evidence that prior infection can kind of serve as a functional first dose, and then the first dose of the vaccine would be a booster, and they may not necessarily need a second shot right away? Any thoughts on that concept as it's kind of new and emerging?
Hi, Mary. I think that's an interesting question. I think that we don't know enough to make any kind of recommendations around that.
Okay. That was very selfishly my own interest. So thank you for that one, Dr. Iwamoto. And this was an interesting question that popped up. It was published that Pfizer was less than 75% effective with Asian participants. Are there any thoughts on whether Moderna might be better or recommended instead for people of Asian heritage, or do we have any data on that?
Mary, I'd have to go back and look at the exact data. From what I can remember, we didn't see a lot of differences across race and ethnicity, but there certainly is not a preferential recommendation at this time for using either one vaccine over the other for the prevention of COVID-19 in prioritized patients.
Okay, great. Thank you so much. And I think we are unfortunately at time. There are a lot of great questions, but I encourage all the participants that had unanswered questions. There's a wonderful provider toolkit now on our New York City vaccine provider page. So I encourage you to take a look. There's probably a lot of answers to your questions in there. But in the meantime, thank you to our panelists. Thank you to everybody for joining us. And we look forward to joining you again in 2 weeks. So thank you.